Order. I call the meeting to order. This is a standing committee of health. I'm John A. McDonald, the MLA for Hants East and the chair of the committee. Today, we will hear from the Department of Health and Wellness, Nova Scotia Health, the Department of Cybersecurity and Digital Solutions, and the College of Physicians and Surgeons of Nova Scotia regarding protection of health data. Just a reminder to put your phone on silent. I'd also like the committee to welcome our newest member, Carmen Kerr. So now I'll ask the committee to introduce themselves, just stating their name and the consistency, starting with the newest member, MLA Kerr.
Carmen Kerr for Annapolis.
Good afternoon, everybody. I'm Braden Clarke, the MLA for Bedford South.
Hi, Gary Burrell, Halifax, Chebucto.
Hello, Sue LeBlanc, MLA for Dartmouth North.
Yeah, hi, Nolan Young, MLA Shelburne.
Good afternoon, folks. I'm John White, MLA for Clay Spain Dominion.
Good afternoon, Chris Palmer, MLA for Kings West.
Good afternoon, everyone. Trevor Boudreau, the MLA for Richmond.
For the purpose of Hansford, I'll also recognize the presence of Legislative Councillor Gordon Hebb to my left and Legislative Committee Clerk Judy Kavanagh on my right. So I'd like to welcome all the witnesses. What we'll start first is your name and your position, and then I'll go to opening remarks, and I will start with Mr. McKenna.
Scott McKenna, CIO with Nova Scotia Health and IWK Health.
I'm Karen Oldfield, the Interim President and CEO of Nova Scotia Health.
Good afternoon, Colin Stevenson, Chief of System Integration with the Department of Health and Wellness.
Good afternoon, I'm Dana MacKenzie. I'm the DM of the Department of Health and Wellness.
Good afternoon, I'm Natasha Clarke, the Deputy Minister of Cybersecurity and Digital Solutions.
Good afternoon, I'm Tracy Fiander Trask, and I'm the Associate Deputy Minister with the Department of Cybersecurity and Digital Solutions.
I'm Gus Grant. I'm the Registrar and CEO of the College of Physicians and Surgeons of Nova Scotia.
Okay, thank you. So going forward, I'll recognize that the mic will go on just for introductions. They're used to me, so they keep going. So we have some opening remarks. I believe Ms. Oldfield, MacKenzie, Clarke, anybody else?
Dr. Grant.
Oh, Dr. Grant. Okay, so I will start on my left for Ms. Oldfield. Ms. Oldfield.
Thank you, Mr. Chair, and thank you for the opportunity to address the committee. As Nova Scotia Health continues to expand access to digital health platforms, protecting health data remains a top priority. In a world where technology offers incredible opportunities for patient care, we are committed to ensuring that the information entrusted to us is kept safe and secure. We do operate within a controlled network designed to control access. We have processes and policies that dictate how data is requested, how it is accessed, how it is used, depending on its category. Working with our government partners, our goal is to protect health data. We comply with both provincial and federal legislation and adhere to all regulations concerning data storage and privacy, working with internationally certified privacy professionals who help ensure that every requirement is met. Terms are also built into our contracts with vendors to ensure data security is upheld across all partnerships. The journey of health data often starts on paper, but we ensure that paper records are stored either at NSH or secure facilities and digitized before being securely destroyed based on current NSH retention policies. As we expand digital access, platforms like OPOR, which is the acronym for One Person, One Record, and Your Health NS, are revolutionizing patient care, and we've seen some great positive feedback. Through centralizing health data, patients and healthcare providers alike experience the benefits of easier access, more coordinated care, and a seamless user experience. As of today, over 400,000 Nova Scotians have downloaded Your Health NS. While a small number opted out initially, many have since chosen to opt back in, demonstrating the value that they see in these systems. Nova Scotia Health is committed not only to providing the best care, but also to maintaining the highest standards of data protection as we innovate. We want to give individuals the confidence that their health information is safe and secure in modern environments with the highest security standards, and data is not accessible to vendors or even to healthcare professionals unless they are strictly authorized. Thank you.
Thank you. Ms. McKenzie.
Thank you to the committee for the opportunity to be here today. During my last appearance, I spoke about how our healthcare system is interconnected, how we must be innovative, solution-focused, and capitalize on opportunities that improve healthcare. Most importantly, our decisions must be patient-centered. These are fitting themes for today's discussion. To continue improving the future of healthcare, we will begin to rely on more investments and partnerships that will advance digital health in the province. Access to data and information is how we plan, manage, and allocate resources in healthcare. It's how we give patients and providers more control over the care they receive and deliver. Projects like One Person, One Record, a province-wide clinical information system that will further connect and unify our healthcare system. We created Your Health NS, a one-stop shop for healthcare information, resources, and services that has grown to give Nova Scotians electronic access to immunization and medical records. In fact, Nova Scotians want to access more records than we're able to provide at this moment. This shows people are taking more ownership of their healthcare, something the app was intended to achieve. Partnership with tech leaders like Google Cloud will create efficiencies for healthcare professionals. Healthcare professionals must search through handwritten or scanned pages of medical records to prepare to see a patient. In some cases, hundreds of pages, an impossible task. Soon, they will have better tools to help them. Integrating solutions into systems already in use in the province will allow them to search records faster. It will help inform decision-making and ultimately improve patient outcomes. Technology has become a big part of how business and other sectors are providing better, faster, and more convenient services to consumers. Healthcare is no different. Healthcare has gone high-tech. We must keep pace, but that does not mean we should move blindly. The protection of health data is a priority as we expand access to digital platforms and integrate new solutions. We have strict measures and policies in place to protect health data from being misused, like the Personal Health Information Act that helps us strike a balance between the collection and use of health data. There are provincial and federal regulations that must be met in terms of where data can be stored. For example, if data cannot be stored in Nova Scotia, it must be stored in Canada. This is built into any contract with a vendor before we will work with them. The future of healthcare isn't down the road, it's here, it is now. We're embracing that future in Nova Scotia and taking steps today to prepare for tomorrow. Thank you, and I look forward to your questions.
Thank you. Ms. Clarke.
Thank you, Mr. Chair. I'm pleased to be here today to talk about the Department of Cybersecurity and Digital Solutions' role in the protection of health data and the role CSDS plays in enabling and supporting digital access to health information. We live in a digital world. Globally, people are conducting business and arranging their lives online. Nova Scotians need to be able to interact with their government and their healthcare system in the same way. Through our work with our valued partners, CSDS is supporting digital transformation in the healthcare system and doing everything we can to maintain the trust Nova Scotians place in our healthcare partners with their most personal information, their health information. We want to make it easier for Nova Scotians to access their personal health information and feel empowered in the healthcare system to take ownership and control of their health. And it's up to us to meet Nova Scotians' needs in a way that's safe and secure. That's why the Department of Cybersecurity and Digital Solutions was created in 2023. We are only one of 3 provinces with a department dedicated to these important issues, and we're helping to lead the way on how government shapes Nova Scotia's digital future. There are risks, as there are in everything we do every day, and we work to manage those. But there are also so many rewards. We've seen what's out there beyond our borders and what we want to deliver for Nova Scotians. Recently, I had the opportunity to visit Estonia, and there, for example, citizens can access their healthcare records online, file their taxes in under 5 minutes, and start a business online really in minutes, with both security and convenience. Estonia has transformed its entire economy by becoming a fully digital society. We aren't there yet, but why shouldn't we be next? There is huge opportunity for us to deliver secure, reliable services that engage Nova Scotians and help them build trust with their provider and our healthcare system. Thank you very much, and I look forward to answering your questions today.
Thank you. And Dr. Grant, if you had any opening.
Thanks. Again, my name is Gus Grant. I work at the College of Physicians and Surgeons of Nova Scotia. The college is a creature of statute. It was created by the Medical Act, and the Medical Act defines the objects of the college to be to regulate medicine in the public interest. So when we're speaking about the protection of health data, there are many angles which connect with a broad notion of a public interest. So I think I'm here to say that that the voice of patients needs to be heard when speaking of the public interest. Patients who have expectations of privacy, and patients who also have expectations of service from the system that they fund through their taxes. I think it's also in the public interest to represent the voice of physicians who have oaths that they have sworn, and who also deserve clear instructions from the regulator and from the province as to what their responsibilities are as towards the private, confidential nature of the information they steward. But it's also in the public interest to speak of what can be expected of the system writ large. The public interest is served by a system that is efficient, by a system that is armed with data that allows it to learn from itself. It would not be in the public interest to have a singular system as we do in Nova Scotia that had disparately housed data that couldn't communicate with each other. So I'm not really sure why I'm here, except to say that all of these angles, all of these perspectives align with the public interest as it pertains to medicine, which aligns with the mandate of the college. I think we're all collectively here to find that sweet spot that balances these competing expectations that are not totally in tension, but somewhat overlapping right now. So I wish you luck in your work. I'm happy to answer any questions as they may pertain to the work of physicians.
Thank you, Dr. Grant. Okay, so as normal we'll have 20 minutes, 20 minutes, 20 minutes. At the end of 20 minutes, I'll have to say order, not being rude. And we'll start with MLA Kerr for the Liberals. MLA Kerr.
Thank you, Mr. Chair. Thank you to everyone for being here. Dr. Grant, I'm glad you're here as well. I've got some questions for you at the end. With OPOR, One Person, One Record, there's a vendor funding announcement, I think a year ago, thereabouts. And I'm curious about the clinical information system and the launch for Go Live. There was reference, I think, on the website and on a press release for February 2025. Are we on track to hit that target?
Is that going to be Mr. Stevenson or Mr. McKenna? Mr. McKenna. Mr. McKenna. There you go.
Thanks very much for the question, honourable member. One Person, One Record is the Oracle Health solution that we're putting in our hospital acute care systems across, excuse me, across all of our hospitals across Nova Scotia. The biggest return out of that isn't about digital. It's about clinical standardization. So we're having the same processes deliver patient care from end to end across this province, no matter which hospital you actually end up in, and then digitizing that, getting rid of paper. So that is the biggest return out of that, to improve healthcare and patient safety for Nova Scotians. Where we are with the process of that, this is a large multi-year initiative. The current plan right now, as walking through, is the IWK will be the first site go live, which is different from the original plan that was developed pre-contract. And it will be in August 2025 will be the first site go live. And that is because IWK is more of a singular health authority, and actually we can put that in place first without having, because we're doing a provincial build. Any other hospitals, we want to make sure it's done and it applies to the rest.
MLA Kerr.
Thank you, Mr. McKenna. So am I right to say the initial announcement was a 2-year rollout? I believe it was Dartmouth General, Cobequid, I think it was Bayers Lake as well. Has that now shifted to only the IWK site, or are those other sites also as part of that initial rollout?
Mr. McKenna.
It has not shifted. The sites going first and second in the order have shifted. So we've, instead of going to Dartmouth General first, which was the original plan, IWK will go in August 2025. They will follow after that with 2 rollouts in the central zone, Halifax area, more around our, Halifax Infirmary and respective hospitals, and Dartmouth General in Cobequid. And then subsequent to that, we'll do the rest of the zones. Although the timeline from the original go live seems to be pushed out, it's delayed. It's actually have the right to make sure we do it properly. The end rollout is actually within the same window, about a few weeks difference at the end. So the whole project still is on schedule. It's just shifting on the implementation.
MLA Kerr.
Thank you for that clarification. So I think the website, or physicians.nshealth.ca, still talks about those initial sites. So I don't know. I've had a couple questions about that. I'm curious of what training process or supports are there for employees as we roll that out over the 2 years. So has that training for employees to shift to that new system already started? Has it started at IWK, and does it already start for the other locations that are following suit after that?
Is that going to be Mr. McKenna?
I'll come back to we're standardizing our clinical processes, right? So all clinicians in the province are represented and establishing those new processes and those the norms that we will have in Nova Scotia, and that in itself is the huge change management of this. When we talk, I will go to the training, but that is in itself the training, because clinicians themselves, our physicians, are designing the the workflow to be put in place. The digital implementation is taking those workflows and just digitizing that and configuring the system to that. So part of that training actually is that change management, is the work that's ongoing now by having across all of our departments, changing the way we do it, so we standardize, and it has buy-in. It's built by the clinicians, by the physicians, and then we're just going to digitize that and put it in place. There will also be training for people when we go live. Absolutely, and we will have, as we've learned from other sites across the country who've done this, we will have people at the elbow right in the hospitals with our clinicians to support them for all those go lives when we do that. So the learning, the development, the standardization now, and then the actual implementation and the support for the training for that during go lives.
MLA Kerr.
My understanding is the OPOR team has been traveling through the province, and there's been virtual town halls, I believe. I think there was a survey conducted between February and mid-March this year. Could anyone comment on the feedback that emerged from those town halls and surveys, and specifically how we've taken that information, if we have done so, and implemented it in our OPOR? Thank you.
Oh, Ms. Oldfield.
Thank you. I don't think that neither Scott nor myself would be able to give the specifics around that, but if it's critical, mission critical, we can certainly tally the feedback and share it. There's nothing to be hidden. We just don't know it ourselves.
Okay. Emily Kerr is fine. We'll get it later. Thank you, Emily Kerr.
Thank you. So that's great. Yeah. And it was more about how we're using that information more than specifics, but I will take any offer for specifics as well. I want to switch topics to the privacy breach at St. Martha's. Earlier in this year, I think 2,000 people, their information was accessed. And I'd like to know, despite, I assume there were safeguards in place, how did that breach occur? And I don't know who best is here to explain that.
Ms. Oldfield, the senior lead forwarder.
Yes. What I can share with you, so let's start at the end and then work our way forward. I think we are aware of the fact that the individual at the end of the day was charged under the under FIA, and so the matter is currently before the courts. I periodically see a little notice in the paper just referring to it. So I'm going to be careful what I say so as not to jeopardize any proceeding before a court. I can tell you that the particular matter actually surfaced through a fellow employee and was reported accordingly, which is exactly what we want to have happen in our policies. And it was fully investigated, and the matter took quite a while to investigate. As the deputy mentioned at the outset of her comments, there's a lot of paper, and there were a lot of records, and it took a long time to make sure that everything was properly accounted for. And so at the end, the individual was terminated, and the matter was referred to the appropriate law enforcement agencies under the Act, and subsequently charges were laid, and that is what I can share.
Emily Kerr.
Thank you for that response. I guess the next question would be, from what we've learned from that, understanding the sensitivity to the issue, what specific steps have been taken since that incident to ensure it doesn't happen again, or it doesn't happen again for a long, long time?
Ms. Oldfield.
First and foremost is, I think the very day that this all occurred, I personally delivered a message to our employees reminding individuals of our commitment to the protection of privacy under our code of conduct and under the law. That was followed up by a very intensive educational process. Every employee who begins at Nova Scotia Health is required to take a privacy course, and so that was refreshed for those who wanted a refresher, and were strongly encouraged to have a refresher. As we know, sometimes from time to time laws change and are updated, and it's important for people to be aware not just of the law, but also of the code of conduct and our expectations as an employer, and our expectations as members of the public, our patients. So that was on the one hand, and then I think we also took some technical steps, which I'll defer to my colleague, Mr. McKenna.
Mr. McKenna.
Yeah, so we think about some of the stuff too, as the CEOs mentioned, Ms. Oldfield. Education and awareness is paramount. So we continue to the email immediately and continue to weave that education and awareness to all employees about their responsibilities and the privilege that they have with access and controls to do their jobs, which means access to health data. The second piece is a review and make sure that we do have the appropriate access and controls on the systems that are placed. And each employee has access to what they should have access to, but do not have access to what they should not, what they're not authorized to have access to. And then the third piece, reviews, and these were already in place, we reviewed it as well, is it doesn't stop the event from happening, but how do we actually react to it? Do we have the right audit capabilities in place? So when it does happen, unfortunately, when it does, we do have a bad actor and it happens, how does that get triggered? How do we get notified? How is that tracked? So we can actually respond to that quickly, efficiently, and appropriately. And in this case, bring in the authorities.
MLA Kerr.
Thank you for that response to both of you. Switching topics, just to highlight Section 110, the Personal Health Information Act, and some questions around that. My understanding is the Premier and Doctors Nova Scotia have committed to establishing a data governance framework, providing a formal commitment outlining parameters from collection, use, disclosure, disposal, I believe, of personal health information. My question is, has this framework been created?
Ms. McKenzie?
Thank you for the question. Yes, I'm just pulling up the section of the Act, Section 110, and it's a regulation-making power under the statute, the Personal Health Information Act. And the regulations known as the EHR regulations, the Electronic Health Regulations, were passed in June of 2024. And those regulations govern the use of the EMR data that comes into the system. And there is a very well-functioning working group and a standing committee between the college and Doctors Nova Scotia and NSH and the department to discuss these issues. I believe the group meets bi-weekly. And we're working through, and it's that key work that allowed the launch of Your Health NS, the app. So there's a lot of coordination, a lot of collaboration, and some really great conversations happening now between those entities.
MLA Kerr.
Thank you. My understanding is the Privacy Commissioner wasn't consulted on that piece of legislation, despite its impact on privacy and access for Nova Scotians. My question is why?
Ms. McKenzie. Hi.
Sorry.
That's okay.
Through the chair. Thank you, Mr. Chair. A privacy impact assessment would have been done with respect to all of this work. And there's no statutory requirement, I believe, to discuss that with the review officer. But the great collaboration between Doctors Nova Scotia, the college, ourselves, the review by the privacy impact assessment piece was considered sufficient to ensure that the various privacy interests and system interests were represented.
MLA Kerr.
Thank you for that. The Act was passed giving government access to patients' health information, as we all know. And I think in quotes, it said planning and management of the health system, resource allocation, and I'm reading, pardon me, creating and maintaining electronic health records and services. My question, did the department consider different or alternative methods to accessing this information, i.e. through hospitals or care clinics, just to maintain that aggregate anonymous data, or was this the clear path forward?
Ms. McKenzie.
Sorry, Mr. Chair, I'm going to get better at that.
The benefit was at least I knew who I was recognizing, so it's okay.
I'm too fast off the mark sometimes.
It's good.
So with respect to the creation of the regulations, the other consideration of other sources with respect to the sources of the data. The goal of the Your Health NS app is to actually give the records to the patients with respect to their primary care records, so that the source for those is the EMR data. And so that's why those regulations passed under FIA are focused on EMR data. So the actual app itself draws information and data from hospital systems, clinical information systems inside the hospital. I'm going to look at my technical experts here quite frequently and my voice will drop off. So we're always looking for the least intrusive method of data collection, but also because we have the joint goal of, in this particular case, getting Nova Scotians' records into their hands. The EMR data was the target in terms of trying to make that legislative change and the regulations in order to advance that goal.
MLA Kerr with a little over 4 minutes.
Oh, Thank you, Mr. Chair, for that heads up. I think when these amendments were first introduced, again, Section 110, Doctors Nova Scotia, the college, I believe, raised concerns about the potential risk of granting the Minister of Health unrestricted access to personal health information. I did read, Dr. Grant, your correspondence for law amendments a couple times through, and I do believe they secured a commitment from the Premier that ensured that the Minister's access to data was, you know, appropriately restricted, whatever that may look like, and the Act has since passed. My question would be, what regulations have been developed in collaboration with the government since then? So, or what regulations and/or have been introduced to ensure that the minister's access is regulated? Thank you.
Ms. McKenzie?
I can begin and then have Dr. Grant actually weigh in to answer it fully. So the EHR regulations, through the collaboration with Doctors Nova Scotia and the college, provide that when electronic medical record information comes into the minister is a custodian of personal health information under the Act as well, and has been since the passage of FIA in 2010. When it comes into the side of the system that the minister would have access to, it's de-identified and aggregated so that it's not identifiable to an individual person. So that is actually expressed in the regulations, the EHR regulations that I referred to earlier. So that was taken on board, obviously, and was always a goal. You know, the minister's, I think, comments in the House were to that effect as well, and the regulations simply followed on after the passage of the amendment to the Financial Measures Act. So that protection is there in the regulations, that it's de-identified and aggregated in the hands of the minister for the purposes of system planning and resource allocation and all those things. I'll hand the microphone to Dr. Grant.
Dr. Grant.
I think the deputy has explained, has answered your question as to regulations. I can say there's been good faith, earnest discussions with government, the college, Doctors Nova Scotia, other interested parties about how to manage this. This is delicate stuff, but the first step, which was one of the thrusts of my submissions to law amendments, was that we wherever possible, have de-identified aggregate data. That's the data that will help the system learn from itself. And when the discussions we've had at the various meetings, and I didn't realize it was bi-weekly, but it may be, and I may have missed a few, have been thoughtful discussions about what information is needed, what information is not needed, and how to manage information so that it can be shared safely and appropriately. You know, take the example of the app. I wouldn't want a patient to go on the app and see the result, a worrisome result of a biopsy, without having it screened beforehand. Do you know what I mean? So there's medical input, and I think it's Dr. Ashley Miller and is it Aaron Smith, Doctor? So there's a thoughtful group of doctors trying to say, okay, how do we sensitively manage this information? So whereas my submissions to law amendments speak for themselves, I've been pleased with the engagement of government and everyone in the discussions since that time.
Emily Kerr, 10 seconds.
Thank you for that response, and I hope I have more time in the second round. Thank you.
Thank you. And next will be MLA LeBlanc.
Thank you very much, Mr. Chair, and for the discussion thus far. I have some thoughts on the app that, if we get to it, I'll share later, but I was just trying to sign in again, and turns out I need to redo my sign-in, so that'll take me an hour. But anyway, first question is for the college, first couple. Since the changes were made, you may have referred to this a little bit, but since the changes were made to the Personal Health Information Act last year, has the department consulted with the college? Now, you referred to the biweekly meetings. You may have missed some, but has the department consulted with the college or the members on the regulations and data governance as they pertain to access of the use of personal health information?
Dr. Grant.
Yes.
Yes. Okay, great.
MLA LeBlanc.
And then in April, the college released a statement noting that it would become a member of the committee. And so, can you elaborate a little bit on your positive feeling about those meetings? So thus far, you've said that you refer to a couple of people. I'm sorry, I can't remember the names, but why is it feeling positive in particular?
Dr. Grant.
Well, I think the content of the regs that the deputy just described satisfied my immediate concern that wherever possible we should have de-identified aggregate data. I don't want to walk back what I said to law amendments. I would have preferred to see that in the act, but I'm delighted it's in the regs. I think the discussions at these meetings, and I hope you're not auditing my attendance, but the discussion at the meetings were, okay, how do we sensitively move the system forward without compromising the patient's perspective? I think there's, as I tried to outline in my opening remarks, there are first principles that are in tension here. Patients expect confidentiality, but they also expect a system that learns from itself, right? Doctors have an oath to confidentiality, but they don't want that to be an impediment of a system that's efficient. So I've been pleased with the discussions that we're trying to find those sweet spots. And I think every voice has been heard. And so I think it's been a positive step.
MLA LeBlanc.
Great. So just one more follow-up. So back in April, again, you talked about how this, you feared that this would alter the the doctor-patient relationship. Are you satisfied that what you've seen thus far leaves that alone, or do you still think that it's fundamentally going to change given,
Dr. Grant.
Thank you, Mr.
No worries.
Chair. I certainly haven't had any complaints or concerns expressed to the college that would allow me to anchor an answer to your question and with a specific. I think there are generational things to consider. I think older patients take a view of privacy differently than younger patients do. For instance, I think there will be equity-deserving groups that may be a little bit more suspicious than others. So I think there's change management, cultural work to do with this. But the law is what the law is, and the movement now is and the wheels are moving right now to build a system that better learns from itself, and we will have to, in medicine, educate our patients accordingly.
MLA LeBlanc.
Thank you, Dr. Grant. This is for the Department of Cybersecurity. So we have been increasingly turning to private companies to deliver app-based healthcare, as we know and we've heard a lot about. But do we have safeguards in place to protect the personal health data of Nova Scotians if an app like Maple or the app, capital A app, experiences a data breach? I mean, no, actually, forget the capital A app. Let's just use Maple as an example. An external vendor or whatever you call it, what are the safeguards that are protecting Nova Scotians if that company experiences a data breach?
Ms. Clarke.
I'm happy to address the question, and then I would look to my colleagues to speak further if there's anything in addition to the FIA piece, as that's not in our area of responsibility. But government has standard terms and conditions and additional contracting pieces that we would include in those types of contracts that we would have with private sector companies around both privacy and cybersecurity. I think Deputy MacKenzie addressed some of the pieces around data residency, for example, which is important to make sure that we have data residing in Canada and not elsewhere. And then obviously abiding by our, privacy by design principles and security by design principles, but there are contractual obligations that companies would have to meet in order to be procured and to be used and leveraged.
MLA LeBlanc.
Thanks. And would you, in your experience, does using a company that might have data from Nova Scotia but other places as well, could that cause a unique or additional security risks if an organization or a company has data from a bunch of different jurisdictions?
Ms. Clarke.
Or should that matter?
That's a very, I appreciate the question. It's a very generic kind of question, so I think it's one that would require, again, contextualizing and understanding the situation. Certainly, best practice would have us have segregated data, for example, having our own tenant. So we use Microsoft 365, for example. We all use it. And we certainly know there are lots of other organizations globally that use Microsoft 365. Our data, for example, is our data. That data would not be shared across those boundaries, and it's called a tenant. But in terms of answering that, that's the kind of general answer to that question. I would not see on first blush that there would be any risk or concern, but again, that would have to be grounded in a specific use case.
Emily LeBlanc.
Thank you. So this is a question for the Department of Health and Wellness, or NSH. On the topic of virtual care, a study from Canadian researchers released earlier this year found that some virtual care companies aren't adequately protecting patients' private health information from being used by drug companies and shared with third parties that want to market products and services, and that the for-profit virtual care industry valued patient data and appears to view data as a revenue stream. So does Maple or any other government partner in virtual care or digital tools use data in this way? That's my first question.
And who's Mr. McKenna? Mr. McKenna, there you go.
Thanks. So unequivocally, no. When we, to Deputy Clarke's point, when we bring any type of technology or company, we do an assessment of the technology to make sure it meets the Canadian standard for protection of health information. When in Canada, it's protected B classification. So you do the security assessment of that. And it's our data. That becomes part of our Nova Scotia environment, whether it be a cloud environment with Microsoft or Google or Oracle, whether it be Maple in this case. That's part of our environment. Companies do not have access to that data. Their technology does. And it's our patient data that we protect. It's not shared it's not the companies to share or to access.
Emily LeBlanc, just a quick question. Were you reading from a report on that?
I was, yeah, I can table it.
That thing. As long as you do by the end, it's all good. Thank you.
Yeah.
Emily LeBlanc.
And those rules are expressly prohibited in contracts with those vendors, companies?
Mr. McKenna.
Yes, we have the security clause that goes into it, and there's I think the Deputy MacKenzie mentioned earlier, same thing we talked about Nova Scotia, Your Health Nova Scotia. There's a privacy impact assessment and the threat risk assessment, as we do with all technologies, to put the data security and the privacy of our health information at the forefront of everything we're doing.
Emily LeBlanc.
Just a question about this. So, there's been data breaches. I got one of those letters as an employee of the province or someone who gets paid by the province, and said, your information was compromised, blah, 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 blah. But just so you feel better about it, we're going to give you a year of free credit checking or whatever, monitoring. And that's awesome. Great. That's great. But what happens, when, they send me the TransUnion thing sends me the thing that says, actually, yes, you've been compromised. So I'm just wondering, when you talk about these companies have to adhere to all these, to these strict rules and stuff, is that literally what it is? They have to provide a year of free credit checking, or is there much more to it? Please say yes.
Who wants to take that one? Mr. McKenna.
If this broader piece there, she may want to weigh in. So we need to, going back to protection of our data and the privacy of our health information is paramount. There are 3 types of events that can happen. The first one is making sure that our information is secure, and that's why I'll stand here and say that we implement to this Canadian standard for health information, the technology is secure. The second type of event that can happen is obviously we talked about earlier. We have an individual has access to data, and that's bad actor. That cannot be prevented. You can put controls in place, and you can react to it. The third type of information event that can happen would be you can have the most secure technology that you have. The company itself may have a vulnerability in software. We see that every day with events, and I will defer the next piece of that to Deputy Clarke. And how we react to that as soon as that vulnerability by the company, which sometimes is global, becomes aware, it's how we react to that to make sure that patching is put in place immediately and critical. So those are the three types of events that can happen. Two of them are you can mitigate, but you can't prevent. One, we can mitigate as best as we can down to zero. And that's what we try to do.
Emily, I was going to ask Emily LeBlanc if you were good or not. So Emily LeBlanc.
Yeah, that's great. Thank you for that. To the college again. So in 2022, the College of Family Physicians of Canada released a report that stated for-profit virtual care presents a problematic approach to healthcare delivery, as these models are fundamentally designed to maximize profits. Would you, would the Nova Scotia College agree with that? Is that a view you share? And could you speak more broadly to any concerns with virtual care as it relates to quality or continuity of care and patient data?
Dr. Grant.
Wow, that sounds like a graduate level, a whole year of a graduate level course. I would say this: virtual care is here to stay, and I hope that we have the focus to evaluate it, to evaluate that it's helping patients, that its outcomes are real, and that it's cost effective. I don't ascribe to the views of the College of Family Physicians, which sounded from the quote you provided that they were vilifying all private platforms for virtual care. I think it serves no one any good to make that judgment right now. Private virtual care is here, and what we should be trying to do is make sure it's delivered safely and effectively to the benefit of patients. I think the issue with virtual care from my perspective is, are we respecting the paramountcy of patient choice when they choose whether to see? I think it's incumbent on physicians to offer both virtual and in-person care, and it's incumbent on physicians to exercise professional judgment as to whether virtual care is appropriate for the presenting complaint. So there are standards of the actual care delivered that have to be enforced. There are rights of patients that have to be considered, and again, we have to measure and evaluate, right? And we're in the bit of this trough right now where it's become completely normalized in medical practice, and we're only now starting to accumulate the data to measure whether it's been effective or not. So I tried to answer a number of the aspects of your question, but it was a big question. So,
Emily LeBlanc with 6 minutes left.
Thank you. Well, those are the tabling documents.
Thank you, Emily LeBlanc.
Yeah, my next question literally says virtual care is here to stay. I can't even say it. Is here to stay in some form. But this is actually a question for the Deputy Minister. Is the partnership with Maple also here to stay, would you say? Or is the government looking into developing capacity to offer a more fulsome virtual care, sort of in-house virtual care system?
That would be for Deputy Minister McKenzie. Just a second. There you go.
Thank you. I'm going to ask my colleagues from the NSH to speak to the virtual care piece, and then with any follow-up, if that's acceptable to you.
So, Ms. Oldfield.
Sure, I'll start. There are, as just has been mentioned, there are quite a few organizations now offering a form of virtual care. So that would include TELUS Health. There's a number of different companies which have an offering. And so I think if we start with the premise that virtual care is here to stay, then I would see a day where we would actually put this out to see the offerings that the various companies can provide. And it may not be the same for all companies. Like, for example, you may have a company that specializes in mental health as an example, or in different aspects of the health system. And I think it's incumbent on us to actually see what the entire suite is and then go forward from that. So I'm going to start there. I have to say, Maple's been a good partner, and they definitely stepped up and had a product when required at the outset of COVID. Now, it's 5 years later, and we have the opportunity to sort of look across the board and to see other companies which have developed excellent products as well, to see if we are getting the outcomes and at a cost which is affordable for the Nova Scotia taxpayer.
I just one sec. Emily LeBlanc, do you need more?
I just have a clarifying question.
Okay, Emily LeBlanc.
Yeah, so I guess that's great. That's very helpful. But do you ever see a day when we bring it in-house? That was the other part of the question.
Miss Oldfield.
One never says never. Because I look at our virtual emergency, which in, good parts of it are actually, well, first of all, the technology was developed by Dr. Jan Summers at the Colchester Regional. So a Nova Scotian developing the technology using, Nova Scotia tech with Nova Scotia providers in Nova Scotia institutions. So I think that's a great example, and I also believe where we can develop the capacity and do it, then we should be looking at that, yes.
Emily LeBlanc with 2.5 minutes.
Dr. Grant, you referred to the importance of virtual care. Do you hear from physicians or members who want to increase their practice of virtual care, and how could they be greater supported by the government to do that, if you're hearing that from them?
Dr. Grant.
I think there's broad support for virtual care throughout the physician ranks. I haven't heard for calls from physicians about looking for greater support from most of the physicians are working as hard as they want, as fast as they want. So I think there is there's still some tension, some wrinkles to be ironed out. There are patients who often want to be seen in person, and sometimes that doesn't align with physician scheduling and vice versa. And there's tension within the medical profession too, insofar as I'm hearing from consultant physicians that referrals aren't as thoroughly worked up by primary care providers as they once might have been. So this is I would think quite predictable growing pains of 5 years ago virtual care didn't exist, and now it's absolutely a staple in the delivery of care, and I think we're still learning how to best use this tool. So again, I would say if you surveyed all the physicians in the province, the percentage of them saying that virtual care is not here to stay would be inconsequentially low. Are there things lessons still to be learned? Absolutely. Are we getting better at it? I hope so. Are we measuring it? I hope so.
Emily LeBlanc, 45 seconds.
Is there a standard or a standard of how long someone should wait to see a physician in terms of primary care?
Dr. Grant.
Or do those kinds of standards exist?
Doctor.
That would be impossible to impose. There are primary care providers whose practice is almost exclusively chronic disease management, such that you can wait a long time to get an appointment. There are other primary care providers who incorporate a degree of episodic or acute care and thus have same-day bookings available. It would be absolutely impossible to mandate a requirement like that.
Thank you, Dr. Grant, with 2 seconds. So, go to PC, MLA Palmer.
Thank you, Mr. Chair, and thank you, everybody, for being here this afternoon. It's a very important topic for us to be speaking about this afternoon, and I take some of the comments that have been made this afternoon. I appreciate, Dr. Grant, your comment about finding the sweet spot. between patient privacy and getting better management of the system with data. I think we're getting there, and I think it's important. Hopefully, Nova Scotians are hearing the information and that we're hearing this afternoon. They get a chance to learn more because it is about education, I think, the more we're moving forward. I'd like to ask my first question to Deputy Clarke or ADM Fiander Trask. So last year, the government created the Department of Cybersecurity and Digital Solutions, and you outlined in your opening remarks that they're one of 3 provinces in Canada. So I think we're on the leadership end of that point. Could you please outline the importance of having a dedicated focus on these areas and expand on what you've spoken about so far, but just talk about that for us.
Ms. Clarke.
How much time do we have?
18 minutes, 51
okay,
seconds.
Excellent.
He's done it before.
Okay, no problem. Thank you very much for the question. Not to be cheeky about it, I'm actually incredibly proud of being the province's first deputy minister of a department like this. We know, for example, that cybersecurity attacks, cyber risk is the single largest business risk facing the globe today. I think it really demonstrates the province's commitment to emphasizing a focus in this area. But what I also don't want us to lose sight on is the digital solutions part of the name as well. And why I think that's really important is that the focus and the approach we take in our department is putting the needs of users first. So when you think about the technology that you interact with today, which you probably don't think about it, it's on your phone, it's easy. My son loves Uber Eats. So that's what we want to offer up to Nova Scotians is building services with them, designing them with them, understanding their needs, not just focused on government's needs, but how do we meet their needs so that we're designing policies and services that work for them. And I think that also translates into the cybersecurity world as well. We very much put cybersecurity by design as our approach to thinking about how we deliver things. Yes, both of these things can be in tension with each other, but we can't have one outweigh the other, meaning I can have the most secure house, but that would mean every door in my house would be locked and I couldn't flow around and access things. So we have to balance those things, all focused on the needs of users. I'm really proud that Nova Scotia has taken that leadership. I'm pretty certain we were actually province number 2, only just behind Quebec. And the impact that that has had, it has meant that we've been able to have focused attention on these important priorities, working with partners like the Department of Health and Nova Scotia Health, and helping us advance and work in ways that people just expect us to today.
Oh, Emily Palmer, 16 minutes left.
Thank you. So, you know, part of what we do as MLAs is inform and educate people and try to promote what we're doing. And I find a lot of times there's so many things happening, it's hard to keep up with all the things that's happening in our healthcare system. And, you know, we're not only trying to fix the healthcare system that's been there, we're actually building a brand new healthcare system for the future. We know that. And that's what collecting data is all about. So I wanted to ask a question about the app, and I don't know who to direct this to. But we've heard that over 400,000 downloads have been made here in Nova Scotia about this, and averaging about 2,500 interactions per day with the app. Could you please talk about some of the features that are there now? And because again, Nova Scotians, we need to know what is available through that app, and what potentially is coming in the future applications for that as well.
Mr. Oldfield.
Thank you. We're going to share the answer to this question. But I'd like to start by talking about a lecture that I attended last Thursday night at the Faculty of Medicine at Dalhousie. It was the Kinley Memorial Lecture Series, and they had last week speaking Dr. Jane Philpott, and she was asked a question after her lecture, which was on primary health care. She was asked about digital, similar questions. And Dr. Philpott referred to a study of 10,000 Canadians. It's a national study. We did participate in Nova Scotia, and I'm sorry, I just can't recall. I think it was like We Share or You Share something. But it focused in large part on digital. And it talked about the fact that overwhelmingly, Canadians want to have access to their health records, and they want access to these health records in their hand. So I was happy to hear this. I knew of the study, but she reiterated it because this is exactly what your Health NS has attempted to do. And we talk about one patient, one record. And yes, it's going to be a very good thing. Very good for clinicians, helpful for Nova Scotians. But your Health NS actually is one patient, one record in a person's hand. And, Scott will never say this, but I will say that Scott and his team, and there are others here, who actually they created this app in record time compared to other provinces, and it is a very, very good product. Lots of work yet to do, and we're going to keep doing it. But, I just want to commend Scott and his team for the work that they did do in getting this to come to fruition, and I would invite Scott to share some of the newest features that the app offers Nova Scotians.
Mr. McKenna.
Thank you very much for the question and for the comments. CEO Oldfield, I will say, we have an incredible team that's done incredible things across the system. It's almost a year now since we publicly launched the app. It was beginning of November. I was just reflecting right now on that. And the story hasn't changed. This is about empowering Nova Scotians, putting information in the Nova Scotians' hands because individuals make decisions. And if you remember, when we launched this last November, it had no health records in it. This wasn't about health records. This was about giving people information so they could actually find out where they can get access to care in their communities, what information, health information is valid, coming from, not from the internet, coming from Nova Scotia sources, to empower people, to put people in the driving behind the cars, they could drive and get those answers, because individuals make decisions. We've now progressed. We all know that from day one, everyone says, I want my health information. And we heard Dr. Grant talk about, there's a journey to that. We have to, continue that change management in the journey. So we then moved to February. We did a pilot to include some health information. It's not everything, it's some. Then we went to the launch of records at the end of June, which empowered all Nova Scotians to have a certain set of their health records, and that will continue to evolve. We've seen this summer. We've now rolled out, going forward, your X-ray reports and your ultrasound reports. And we all know that's a natural evolution. We will continue to do that because Nova Scotians currently can get access to the health record, but it's very hard. I use the example, it takes, I think I'm fairly informed, and it takes me 10 minutes to figure out how to book a COVID vaccine in Nova Scotia, right? That's the whole point of the app, to empower people and help people press the easy button. So is it perfect? Absolutely not. We have a journey to go. We're on a journey, but we're making incredible progress. Another piece I did want to talk about as we enhance and improve the health system. Right, as Deputy MacKenzie talked about the Act and the regulations, now we're bringing the primary health care data on board. I will reiterate that is only being used and provided back to the individuals. It's their information. We do not even provide that information to our hospital clinicians. That's not within the Act. Personally, as a Nova Scotian, I want to, because I expect everyone who's in my circle of care to have access to my information, including my first responder. But that's a change management, and we'll get there. Nova Scotia will get there. So we're protecting the information in there. What else is coming in the app? We talk about expanding health records. We know that'll come. We already went public, had a conversation at the end of August around the bringing our partners with Google to help the citizen experience, to not just have questions where they're searching for information and they're answering, clicking. They're actually now, you get Nova Scotians, when we launch that piece, we'll be able to talk in real language to the app to find out information about a disease, information about where can I get care based on what I'm presenting. It's interactive and how to get access. So that will continue to evolve. But the core of what we're doing has never shifted. It is about putting the power of the information in the hands of the Nova Scotian so they can make informed decisions. The last thing I will say, because I'm sure everyone has stories about this with their friends, their families, their colleagues. I'll share one of mine because we can't talk about other people's health information. I recently went to see my primary care provider, and I had the information in my hands that she didn't have access to. Because there is no source for health records comprehensive in Nova Scotia. Hospitals have information, primary care's information, first responders have information, but we're trying to bring it down together in one spot. So she asked me, where did you get that? You must have went to a walk-in clinic. I had it there so I could share that with her. And at the end of the day, I don't think it was a patient safety issue for me, but ultimately those can be patient safety issues and patient outcome issues. So we're empowering Nova Scotians to help them manage their health through a health management tool. And it will continue to evolve, and we'll get better at it, and we will manage the risk of, like Dr. Grant said, of what information when, because there's a change management issue as well.
MLA Palmer?
Thank you. Just quickly, Mr. Chair, am I allowed to read a text from someone?
As long as it's tabled, you must table it, so you'll have, not your phone, but the text will have to be tabled.
Okay. Well, I don't have the permission.
And you
to-
will also have to have been given permission.
Yeah, no, fair enough. Well, I'll pass. But I
Okay,
have,
thank you.
I have a good recommendation from someone in Toronto, Ontario who's interested in this app, and said, like, a doctor would like to come to Nova Scotia because I thought of it.
Sorry, what were you saying? You just want to count down your 8 minutes, or MLA Palmer?
I'd like to pass it on to my colleague, Emily Boudreau.
See, he's a hog. MLA Boudreau.
Thank you, Chair. And this is just my second meeting as a returning member of the committee. And the last time I didn't get to ask a question, I talked it out. I enjoyed that a lot. And yeah, there's a few of us here. But you think of data, and I think it's really hard for us to understand how much data we're talking about and how impactful this is, whether it's on the healthcare level or whether it's with Department of Public Works or whether it's whatever. And I would say, I think Deputy Minister Clarke kind of stole what I was going to say is this government has made this a priority. There is no reason outside of making it a priority than creating a department of cybersecurity and digital solutions. And I would say I'm very proud of our government, just as the deputy would say, that we've taken this seriously, and we continue to do that. And then I was thinking about what else I was going to say, and Ms. Oldfield kind of stole a little bit of what I wanted to talk about in terms of my wife and I are both healthcare practitioners. And when we heard about the idea of one patient, one record, and how it would impact our ability to treat and to care for patients in Nova Scotia, this is revolutionary. This is huge, and we're doing it the right way. And I'm really, really looking forward to kind of that perspective and that way. And then I think of the app and how it allows patients to take, and people to take responsibility for their own health. Because as a healthcare provider, I get to spend 15, 20, 30 minutes with somebody, but the rest of the day, they're on their own. And it's about giving those people and empowering people to make decisions that better their health. And what better way than having that data right in front of you? And I say this we're moving the needle, and it's an iceberg, right? You don't get to see what's going on at the bottom, but all that work is going to come to fruition. And I would say I'm very excited about it if you can't tell. But I do have a couple of questions to ask. And the first one is a little bit about the one patient, one person, one record. And I'll direct it to either the department or Nova Scotia Health. And we've talked a little bit about the app. But I know we're continuing to work on one patient, one record. But can you talk to us about the impact of an integrated medical records and data sharing system and what that means to Nova Scotians and what it will do to patient care?
I'm looking. Ms. McKenzie. Ms. McKenzie.
Yeah. I'm going to deputize Chief Stevenson to speak to this, along with perhaps give part of the answer to Mr. McKenna as well, if that's okay.
Sure. Mr. Stevenson.
Happy to start. I think there's been I think this kind of builds on a lot of the conversation around EMRs. I think what's really important for people to understand within Nova Scotia is there's EMRs in primary care, but every clinical information system that exists within the acute care setting has an EMR. And right now within Nova Scotia, within the environment, if you kind of think about it from zones and the geography, the central zone has a clinical information system which is comprised of multiple applications based on service. The rest of the province has a different clinical information system. The IWK has a different clinical information system. When those systems were implemented, even though some of them are a Meditech environment, they were implemented in different ways or different sort of instances across the province. So we have huge variation associated with what those clinical information systems are and how they're used or how they function. Mr. McKenna kind of talked about, we can talk about a clinical information system project, but really it's about changing how people work. It's about changing care and care delivery. So one of the big values associated with moving the entire province through the OPOR process and what that project is really is actually getting us to some consistency and commonality around how we're supporting and delivering care to Nova Scotians across the province. And it's actually creating an environment in which that information that follows me as an individual who may be trying to access care in different parts of the province, I know that information is actually going to follow and be there with me regardless of where I go, and that the clinicians that have the authority to support me in my care actually have the ability to access that information. So the biggest, or one of the biggest pieces really is around that care consistency associated with it and the access of the information, the availability. There's other things which actually are part of what a typical clinical information system would be that Nova Scotia is taking advantage of. And those are things such as their built-in clinical decision support. So they actually provide you with a provider based on the information that's entered with some information to help you support in what that care delivery it is. It allows us to take certain things which are currently paper-based and digitize them or pull them into the entry system so that they're actually there and part of the record. Because right now we have some information which isn't part of that clinical information system as a digitized record. It's still paper-based. And it provides information and training for clinicians as well as information that actually follows the patient. It increases efficiencies within care. It can create more cost-effective care. Most importantly, it actually has the ability to improve the quality and the safety of the care that we're delivering to patients. I'll turn it over to
Mr. McKenna. Do you have something to add?
The only thing I will add to that, and it's germane to the whole conversation today, is, you know, we are doing in Nova Scotia, we're making the impossible possible. And, you know, a lot of, we will be the first province in Canada. And I will say that not to be first, because but it shows the collaboration, doing it the right way, starting with the legislation, the regulations that are put in place to enable us to actually move forward in creating that patient record, that one patient summary. And there's no place else in Canada that will have that. They have it at hospitals. Yeah. In Nova Scotia, we're bringing primary care data, hospital care data together. So we'll have a comprehensive patient summary for any, first of all, for the Nova Scotian. And as we're enabled to legislation and regulations to exchange that, that's what every physician in this province wants. And we'll be able to get there. And then as we continue to implement standardization in other systems, the data will become better, and we will have more data, but it doesn't prevent us from using what we're having today and getting it out there, because every Nova Scotian and every clinician wants to have that so they can give great quality care, safe care, and produce great outcomes. And we're doing that now, and that's what we're on the track for. And I'm extremely proud and humbled to be part of this province, the incredible teams that collectively across the system are enabling that.
Mr. Boudreau with 49 seconds.
Okay. Yeah, I'm probably not going to get to a question, but I think you you think about, and I think somebody had said this to me before. It might have been the minister. You know, like previously you'd be in the emergency room, you'd be being transferred from the straight Richmond Hospital to Halifax, and they'd take your file and stick it under your leg and say, see you on the other side, and hope that data gets there, and hope that information gets there. And I would say, there's risk to not doing this, and we talk about the risk of doing. But what about the risk of not doing this and not moving forward in a way that's going to provide not only clinicians with the ability to make more informed decision-making, but also it comes back to that app where we talk about people being able to take responsibility and say...
Order. Okay, so the next round, we'll be doing 10 minutes each, and it's to the Liberal Party. MLA Clarke.
Thank you, Mr. Chair. Thank you, everybody, for being here. And we've been talking a bit about the importance of records and management. And I think, Mr. McKenna, you mentioned your situation there, and it just made me think of something myself. So I have a condition which is totally fine. It's called situs inversus. So all of my internal organs are reversed in position. So heart's on the right side, you know, liver, whatever. It's all backwards, mirrored. And yeah, and my mom thinks I'm a medical marvel, but basically there's no complications with that. But the point is, you know, I switched family doctors a few years back, and I get EKGs periodically just to make sure everything's going fine. And my family doctor called me and said, "Oh yeah, come in, I got to see you, talk to you about something." Okay, I guess. And she says, do you know you have this condition? I said, yes, I've known this for 30 years, or, you know, ever since I was a little boy. But that data just never crosses over, right? When I switch family doctors. Now, in my case, it's fine, but if it's just your heart, for example, that can cause big issues, right? So it just made me think about that and how important it is to have that coordination. So I think it's really, really important, and I'm glad that we're moving in that direction. I did want to ask about the app as well, because I think there's one piece of it that we hear about a lot is the number of downloads, and 400,000, I think Ms. Oldfield said at the beginning, and that's good. That seems good. That's necessary, but not sufficient, I guess, to show that it's working. So, you know, I have a few dozen apps on my phone. I might use 10% of them, right, in any serious way. So what other metrics do we look at beyond the number of downloads to know that the app is working to move us in the direction we want to go in as a system?
Mr. McKenna. Oh, Mr. McKenna, is it you or someone else? You get the mic.
Yeah. I'll start with, first of all, you know, going back to privacy of individuals is front and center in the way we've designed this as well, right? So we are not tracking individuals and what they're doing. That would be a breach of privacy. So that's starts. So what we do know is how many downloads there are. We do know how many aggregate people have logged into. I think MLA LeBlanc mentioned earlier she was having struggles logging in. So how many unique logins we have. And we do know how many times a certain record was accessed, like maybe looking at your lab data, right? But not by individual. So we have those type of metrics. We get feedback as well within the app from people who are willing to give us feedback. I will say that most people, if they have behaviors like myself, when it's working well, we don't give feedback. We give feedback when things don't work well. But of the feedback we get, we listen to that. And people want more records. People want to change this. So that we take that back to say, how can we improve the app when the roadmap of what strategically what we're trying to achieve. The final piece I will say in that as well, we do have, we know how many people go through the current virtual assistant to get access to care. Not everyone uses that to get access to care, find out where they can get access to care, but we do understand how many people ended up where the endpoints are. So those are metrics that are aggregate that we do track and we can pull while protecting the individual's usage. The last thing on the app will be around how do we actually continue to evolve and listen and while we're meeting there. Most digital applications by government, Singapore is the most digital literate society in the world. And if you can hit penetration of 15% of your population, that's extremely high for government. Not for Apple or Google or someone's TikTok app, but for government. And if we extrapolate, it's about 450,000 downloads, I do believe. A download could be a family of 5 might use the same iPad. Right? So we say 35 to 40% of Nova Scotians' population have the app. The opportunity there, that's extremely high success, and I know we'll do better. We'll exceed that. We'll continue to do better. But the opportunity is what that drives us. It means we have a way to reach out and communicate information and access to that much of the population. It's not the only channel, it's a digital channel. But I think that's where the opportunity lies, that we have that much penetration, that how do we use the tool to maximize that, to reach Nova Scotians?
Ms. Oldfield?
Yes, thank you. Thank you, Mr. Chair. I'd like to just add to that. The other, so in addition to what Mr. McKenna said, based on surveys, we also have demographics, which is very, very interesting in terms of who is using. And I want to clarify as well that we've used the term download here today, but that would also include an individual who is using their desktop computer. So it's not 450,000 people walking around with an app on their phone. Okay, and so I think the demographics are very, very instructive. And so all of this information is able to be used to help us better manage the entire system end to end.
MLA Clarke, good?
Yep.
4 minutes left.
Thank you. Thank you, Mr. Chair. So I'll try to be as quick as I could on this one, but just so Mr. McKenna, just so I understand correctly, I realize that there's no individualized data, and that's totally fine. But you would know, for example, or do you know, for example, what percentage of Nova Scotians who have the app, like how many of those 450,000 have never used it versus have used it, you know, X period of time per month? Like, do you have that kind of information? I don't know.
Mr. McKenna?
No, that would be tracking individuals, and that would, that would be a privacy infringement.
MLA Clarke?
Thank you. Thank you for that. And Ms. Deputy Clarke, I just wanted to ask you a question here. My memory might be a bit off on this, but I seem to recall that the department was announced, and then maybe within a week there was the Move It cyber breach. That was unfortunate timing. My sympathies for that. But I think that was how the sequence of events played out. So right into the deep end there, I guess, from that experience, what particular steps has the government taken to make sure that we don't have that kind of situation again, which I know affected, obviously, lots of institutions and governments around the world, not just here in Nova Scotia?
Ms. Clarke?
Yeah. Thank you. Thanks for that memory. It did certainly emphasize the need for a department such as this. And I think it was, 7 to 10 days, to the point where when we had to issue letters, we had to actually create letterhead. But a couple of things I'll just comment on. First of all, I'm still incredibly proud of the team's response. So we have a major incident process and an incident response process, and so the cyber event itself was actually very short-lived. And then, obviously, we were into communicating with Nova Scotians about the effect of what then turned into a privacy breach as a result of the nefarious actors having access to our systems for a very short period of time. So subsequently, we've published a lessons learned publicly around the Move It breach. We are working with our colleagues across government to improve things like data management practices. So sometimes this isn't always just about technology, but it is about how we are using data, making sure that the data that we are sharing around using technologies like this is what's needed in that moment and not anything more than that. So we've been, an analog government here in Nova Scotia since the 18th century. So we've got some work to do in terms of modernizing those processes to work the way that we do. We've rolled out cybersecurity training across government as well. We're the first line of defense as the individuals in the organization. So raising our awareness and literacy around cybersecurity is really important. Everything we click on, whether that's a link or an email, might be a way that a bad actor can gain access to our system. So I think we all working together. And then, of course, there are a number of other steps that we've taken that I would love to be in a position to share with this committee. Unfortunately, bad actors like to pay attention to the things that we're doing and can use that information against us. So This is, as we've talked about in terms of a journey with an app and continuously improving, that is the work that this department is focused on, and that will be a combination of people, process, and technology to make improvements, to do our best, to be as resilient as possible, to mitigate as many issues or risks as we can. The reality is this is big business now, and so as government, we need to work not just within our own organizations, but also with organizations like the Canadian Centre for Cybersecurity, all of our federal, provincial, and territorial committee.
Sorry. Need the time. MLA Burrow.
Thank you. I think my question would be, Ms. MacKenzie or Ms. Oldfield, for you. I want to ask about a patient's access to records in a different context. The context where, at least in my constituency office, we probably most often hear from patients has to do with when their physician has retired. And they're discovering that it is going to cost a considerable amount of money for them to access the records from the retired physician, a lot of times more than they're able at that moment to afford, particularly if we're talking about more than one member of a household. I'd like to know, are there protocols around this? I mean, particularly as to the charges and the fees, or is it, in fact, is it a matter of what the market will bear, or how does this work?
Ms. McKenzie?
So this answer is more appropriately dealt with by Dr. Grant.
Dr. Grant.
So the physician owns the chart. The patient has an enduring right of access to the chart. The situation you described is quite common, particularly now that many physicians upon retirement or death have no successor in their practice. The common practice now is for, and I've phoned widows, I've rented a truck to get records from garages. It's a weakness in our system now because of the shortage of physicians. The college has a professional standard that requires that the fee charged to a patient is reasonable and reflective of the time involved. So this shouldn't be exorbitant. The most common practice right now for physicians upon planned retirement or planned leaving of practice is to have their records after, they'll tell the patients I'm retiring in 4 months or whatever, and many of them get a copy at that point in time. But upon retirement with no successor, they simply upload the charts to one of the data storage, DocuDavid or Iron Mountain, or I can't remember the name of and then the patient can go there, and that's a situation where the patient charges what is charged what the market will bear. So it's an unfortunate thing. What the most common perception is that the patient owns the chart and are offended by any charge, right? Meanwhile, the physician has been paying lease costs for the space, administrative costs for the staff, and then it takes an hour or two to copy a chart. It costs money.
Emily Burrow.
Thank you for explaining that. But just as you explain it, it sounds as though it might be helpful. Wouldn't it be helpful if there were some guidelines or protocols? For example, we hear from people who say, my cousin paid X, I'm being asked to pay Y. This doesn't enhance confidence. Wouldn't that be a good direction for us to be moving?
Dr. Grant.
There are. There are guidelines and standards on our website.
Emily Burrow with 6 minutes.
Thanks. Well, I'm thinking further about where possibly the department or the authority might be able to be helpful. One of the situations where we hear from people are in instances where there has been a sudden change, sometimes because the physician has passed away, and there all manner of complications you hear about, these would belong in the same category as taking the truck to the garage. For example, people negotiating with executors and so on, all kinds of things that seem kind of anachronistic. And so if it's fitting to ask Ms. MacKenzie and Ms. Oldfield about this, if not, we could ask Mr. Grant too. But would it not be helpful to have a public means by which, in those situations, that data became under the stewardship of the department or NSH, some systematic way it could be dealt with so that you didn't have these kind of anachronisms?
Ms. MacKenzie? I'm just trying to figure it too.
Yes, I'm happy to begin a response and then invite Dr. Grant to take over. The issue actually draws into sharp relief the imperative of digitizing records as best and as quickly as we can. So the problem actually is something that's squarely within our windshield, if you will, because of the urgency of these exact type of situations. So I'll kind of make that statement. But with respect to the actual standard, that regulation is within the purview of the college, and we're always discussing items like this. And that transition piece where we are trying to strengthen and support physicians with respect to the operation of their clinics, that is work that NSH has undertaken in a very accelerated and focused way, so that pending retirements, pending transitions are supported and monitored, and physicians are given attention and support in those periods of time so that we can exactly avoid that type of situation. So I will actually hand the microphone now to Dr. Grant on that piece, but it is something that is a concern for us. That is a topic of discussion.
Dr. Grant.
A few quick points. If I'm not mistaken, I believe FIA prevents a physician from charging for the transfer of a record to another physician. I think that's likely honored somewhat in the breach more than the observance, but that's a safeguard in place for your constituents. A second thing that's relevant is that last year, for the first time, physicians, when they renewed their licenses, were asked, in the event of sudden closure of your practice, who will be the successor custodian of your records? And we advised them at that time that there would be a duty in the subsequent year to identify a custodian. But I'd echo the meta comment of the deputy minister is this is exactly the type of circumstance why we need to be digitized, right? I remember in the build up to this legislation in April or whatever, I said to, might have been Ms. Oldfield or the Premier, if you want an early win on this, assure physicians across the province of successor custodianship, because it's a hassle for everybody, right? And it's particularly it's small numbers, but physicians pass away suddenly or leave practice suddenly or something happens, and very few have taken the time to plan for those successor rights. So I feel for your constituents, because we get lots and lots and lots of calls. We have a full-time presence at our college who's helping with practice closure issues like that. But this is exactly why a digital record will be so much benefit to better benefit than the paper-based records that are still. What are our percentage now? Is it 20 or 30% are still paper-based in primary care? Yeah.
Emily Burrow with 90 seconds.
Well, thanks, and I think it's very clear what you've explained. And I still want to ask, though, from a policy point of view, I'm thinking about that fee, whatever it is within the guidelines that the patient is confronting. Would it not be consistent with the principles on the basis of which we finance access to health care in the province, if the province, MSI, somehow assumed responsibility for that fee rather than the patient privately?
Ms. MacKenzie, I seen you going forward.
Yes. Thank you for the question. It certainly is a reasonable proposition, but in the actual calculation of the fee, given the protections available with respect to the requirement to the college standard, keep it low and reasonable, combined with the supports that are given by the college itself on the transition, I think that there are protections there to mitigate against extremely high charges in those cases.
Emily Burrow, 20 seconds.
Thank you very much for explaining this and laying it out. It's very helpful.
Okay, 1 sec. Heck, do I go back to this? All right, perfect. Emily Trevor Boudreau.
Thank you, Chair. And no real preamble this time. I'm going to direct this one to Dr. Grant, and I would say everybody has a different comfort level with technology, right? Whether it's a patient or a physician, their comfort level with digitizing health information and their ability to use technology is different, right? We're all human, we're all different. But I guess what I'm asking is, like, what advice could the college provide on how government could work with physicians during like a period of transition like this when it comes to the technology? Are there things that physicians would like government to do to help?
Dr. Grant.
There are, but I'd like to echo the earlier positive sentiment I uttered, that I think the college is being heard now. You know, as to the, you know, I can think of a couple of examples, and Scott, jump in. At one of the data governance meetings or whatever, there was as you were trying to populate the app with data and resources, there were links to certain websites. So I scurried down the rabbit hole of one of those links, and it was on opioid prescribing, and it had been industry sponsored, and the science in it was bad, and you know, so we had to take steps to say, okay, how do we vet the links we have, and we were heard, and the adjustment was made, right? Similarly, on what information and when should information be shared with patients, that involves there's an expertise to that, and physicians are being heard on that. I think the succession, the custodianship and succession of charts is a really relevant thing where government can hear from physicians, and maybe best through Doctors Nova Scotia, but can hear of the realities of that. I can tell you, I used to be a family doc in the late Cenozoic era, and that was a real cost. It was a hassle. It was to when somebody was. So we need to find solutions there. I just don't want to. I think physicians are being engaged and are being heard, and there's growth to be done. So I don't have any unction about our involvement today.
Emily Boudreau.
Thank you for that, and thank you, Chair. And I think I'll pass it over to my colleague, MLA White.
MLA White.
Thank you, Chair. Thank you. So we talked today about the importance of healthcare data for the patient and practitioner perspective. And we started to talk about long-term planning and resources. So I'm wondering if, for long-term planning for the Department of Health, so I'm wondering if you can elaborate on that a little bit, on having the data and how it comes to planning workforce and stuff like that.
Ms. McKenzie?
Thank you. I'll begin and then perhaps hand the microphone to CEO Oldfield. The data allows the management in a system in a very deep and impactful way. And in terms of getting access to rolled up, de-identified data to allow us to see what's happening in primary care so that those resources and our health human resource planning, our resource allocation can be appropriately deployed, because it's a finite resource, right? So the data helps us actually plan and allocate incredibly intelligently, and so that's always the goal with respect to that system-wide data. But I'll ask Ms. Oldfield too. She's far more articulate on this point than me.
Ms. Oldfield.
Without information, it is very difficult to manage. It's difficult to organize, it's difficult to manage, it's difficult to plan, it's difficult to allocate resources, it's difficult to figure out how much money a person needs to pay for things. So, we've said, various people today have talked about information is power, and truthfully, the data is the most important piece of information we can possibly mine. I just look at, I'm just going to give a very small example. I mentioned demographics a few moments ago. We know from the demographics that, contrary to what one might think, it is not the very young who actually use Your Health NS. It's actually a different demographic, a very high percentage of persons 70 and above. Okay. Now, what we also know, sometimes the younger can teach the older. I know I certainly learn every day from the younger showing me how to use my phone and this, that, and the other thing. So here's what we did based on the data. We this summer had 6 students who went around the province. They were called ambassadors, health ambassadors, to work specifically in community and with particular emphasis on a senior demographic to help them download the app or put it on their computer, explain what it did, how to use it, how to access, how to get your data, etc. And those students were, they went to as many possible public events, like the Blue Nose Marathon, as an example, a booth there. But they went to seniors' homes, they went to farmers markets. So the data helps us to know, what do people need? How could people use that app more effectively? Very, very, very small example, but it was meaningful in community. So I just share that. And the more kinds of information, and particularly very sophisticated information that we have, then we can better use that to manage the system from end to end.
MLA White with 3.5 minutes.
Thank you, Chair. So all day long we talked about the importance of digitized information and with the health data and medical records. And obviously our side of the floor, we're talking about both sides here. We're dealing with the residents at home or constituents who want to know how their health records are being kept protected and what's going on. We talked about desensitizing information, or depersonalizing, it was called? Depersonalizing? De-identifying. And so we talked about that. We talked about standards in place with the companies you're dealing with. So I would like to give you a few minutes to put all that information in one place so that you can tell us, so we can clip it and we can share it, so we know how we can tell our residents that their information is safe.
Who wants that?
Another 2 hours.
Oh, Ms. McKenzie.
So I will begin, but I'm probably not going to be able to produce any clips about my level of technical knowledge on it, but I think my colleague, Mr. McKenna, can speak to some of the security protections that are at a more technical level, and my colleague, Deputy Minister Clarke, as well. But in terms of the overarching piece, I think the governing principle for health data is always that the minister, as a custodian, has a strong and a very clear obligation under the Personal Health Information Act to ensure that data is only collected and used and disclosed for the purposes for which it's collected and in minimal and for minimally intrusive ways. So the minister takes that, obviously, as any minister would, incredibly seriously, and that colors all of the protections that get built with respect to apps, OPOR, clinical information systems, vendor contracts, all of those things. So that principle animates all of the work that we do in this space. And, that finds articulation in the regulations, for example, that this government passed with respect to making sure that whenever that data comes onto the minister's side of the fire cloud, they call it, it is de-identified and not actually traced back to an individual. So there's nobody, looking at anything in terms of a data lake or anything anything that comes in inappropriately, and that's a commitment that is very clearly set out in the regulations. We also want to hear from the college and and Doctors Nova Scotia, so we partnered with them in those regulations and have an obligation to consult whenever we're moving forward with any type of innovation inside the app itself and what we call the electronic health record. So the commitment is there. In terms of the technical aspects, I'm going to hand the microphone to Mr. McKenna first, and then to Deputy Minister Clarke to perhaps provide some more of the technical protections that can help inform the record.
Mr. McKenna, 33 seconds.
So I can't answer the question. The new investments that have been made over the past few years by the current government have about health transformation. The digitization, we had a good conversation on that today. We need to get there. What we can say is implementation of those investments is done with modern technology that is secure, and privacy and data security is at the forefront of what we do. We can say that it's standard for health information in Canada. It's protected B classification. We ensure
Order.
that we secure it.
Good try. I'm going to allow closing comments. I'm going to start right to left, and I'm not going to miss anybody this time. Do you have any, Dr. Grant, do you have any closing comments?
No, I appreciate the opportunity to appear. Thank you.
Ms. Fiander, Trask, do you have any closing comments since they didn't grill you much?
No, I get off lucky. No, and thank you very much.
Ms. Clarke.
I just want to say extended thanks to the committee today to have the opportunity to come and share a little bit about our new department and to participate in this very important conversation. Thank you.
Ms. McKenzie.
I have no comments. Thank you.
Mr. Stevenson.
No comments, thank you.
Ms. Oldfield.
This is scary, but I'm going to make one.
There you go.
It's something we haven't talked about today at all. So not to open a conversation, but to share, which is some of the tools that we've talked about. We've talked about apps, we've talked about OPOR, but we have to remember how important they are in the context of recruitment and retention of clinicians and healthcare workers across the board. We're talking about students who come from medical school or schools of nursing or pharmacy or OT or PT, and they are coming out of school very versed in digital applications, and how scary it is when they come to work on day one and all of a sudden they've gone back in the past to a time before they were born. So we have to remember how important it is for to encourage, to retain, and to recruit our healthcare clinicians. And so I just want to put that in your minds as we conclude today, and thank you for your time.
Mr. McKenna.
No additional comments. Thank you for the opportunity. Incredibly important topic.
Yeah, I'd like to thank everybody for coming. We don't have a lot of business, so I'm going to take a 3-minute recess. So we are in recess.
background, it would be hard to.
Order. I call the meeting back to order. I'm going to go to the agenda once I get to it. So, under committee business, the first issue is we had a request for Diabetes Canada to be virtual at the November 12th meeting. Is there any objection to that, concern? All the other witnesses will be in person. All right, hearing none, I'm assuming we're okay with that. Perfect. We received a correspondence October 3rd. It's on the agenda, so the only reason I'm going to keep reading this is 2024, a letter to the committee and to the Minister of Health and Wellness from Oliver Eigen regarding request for independent investigation into systematic issues in Nova Scotia Health Patient Transfer System. This item is actually before the courts, so I would like this will stay confidential until it changes, we're not going to be discussing it while it's in front of the courts. Is everybody okay? And this morning, because we received another letter, but I'm just going to refer it as the letter you received from the clerk this morning. There's been no notice for anybody to see it. It's kind of late. I would prefer this be looked at next month's meeting because there's some just concerns on whether we can discuss it or not. Is there any objection to that? Guys are great. So, oh, sorry. Oh, and because both those documents were not publicly discussed, they're both confidential, so they're not to be discussed outside the contents of the emails. I thank you, Mr. Hebb. And I think the next thing is me saying we're going to meet again. Oh, thank you. Is there any other business? Seeing none. The next meeting is Tuesday, November 12th, 1 to 3 p.m., Advancing Diabetes Care. The witnesses will be Department of Health and Wellness, Nova Scotia Health, IWK Health, Diabetes Canada. No other discussion? Meeting's adjourned. Thank you, everyone.